Good morning, sir, and thank you very much to all of you for having given me the opportunity. And so, incidentally, we are on the 6th of December today, and it's a day that probably changed India's history for ever. And I come from a place, for most of you who don't know, is a small district. It's a big district north of Mumbai called Thane. In 2001, an incident happened. It was related to an orthopedic problem, and in which a big tertiary care center was burned down. And that again changed the course of the relationship between a doctor and a patient forever. My talk is slightly going to digress to really serious issues, which are handled in the OPD, in the casualty, but they are, not the smaller issues, or these are having a lot of consequences on the psyche of the doctor, and they affect everyone who's involved with the patient care. So our hospital, Jupiter Hospital, is a tertiary care center, which is one of the largest hospital in this particular district. It's an ultra-modern hospital. We do receive a lot of polytraumas. We do receive a lot of complex cases for joint replacements. We have a lot of patients who are undergoing organ transplant. So we get patients who are multiply sort of injured, polypharmacy, and even patients who are having multiple comorbidities. So over the last 10, 12 years, we have developed a particular style of counseling, a particular theme of, talking to the patient. And everyone, as sir said, talks the same song, or we call it sing the same song. And I'll take you through our experience and what it has been. There is this book called The Patient Will See You Now. This is by Eric Topol, who is a cardiologist. And in this book, it's a very very slow and boring book to a certain extent, but it is quite a scary book for all of us, because it tells us where we are heading now. The times that the doctor will see you now has changed to the patient will see you now. So the patient wants to see you at his convenience. The patient wants you to answer the questions that he has. The more so in case of the urban patient, as Dr. Kapre was mentioning, there's a difference between the urban and the rural patient. The urban patient, or the the metropolitan city patient, will be informed with certain set of information. They are educated by Google, but what is going to happen next in our generation is Google is even going to tell you whether that information is pertinent to them or it's not pertinent to them. So they will not come with bizarre questions, and that they're being scared on the internet, but they will be quite wisely educated. Now let's turn our attention to certain medical legal facts. This is based on the orthopedic journals, the Bone and Joint Journal, the Orthopedic Trauma, and what has been published in the Journal of Injury and Critical Care, that orthopedics is one of the commonest specialty or stream where medical legal cases are being filed world over. Though our mortality is low and these problems are common in trauma, they're also common in arthroplasty. However, in arthroplasty and spine, the payouts are much more higher. And the most commonest reasons for why doctors are ending up paying, or they are found at fault, is either it is because of a failure to diagnose a particular therapy or to failure to initiate treatment. Add to that the hardware failures, non-unions, neurovascular cases. These damages are quite high amongst the medical legal cases across the board. So this is the hospital. So I'll present two case scenarios. I mean, imagine yourself to be in the casualty or as an on-call orthopedic surgeon, and you're faced with these two particular patients. To drive home the point, I've chosen two of our relatively sick patients who presented in the last couple of years. So there's a 23-year-old male, industrial accident, a heavy steel roller has fallen on his right shoulder. He's got a scapulothoracic dissociation. There is a subclavian artery laceration. He comes with a cold extremity. There is extremely bad chest injury, lung parenchymal injury. In short, the patient is in extremis. This is the patient's X-ray. You can see that this, from the word go, is bad news. The issues here were revascularization, ischemia time, hemodynamic instability. And the big problem here is there were no relatives. There were no relatives. He was brought by a contractor and a friend, and the patient has no money. The family also does not understand the gravity of the situation, but here they are the ones who will cooperate with whatever treatment you have suggested. He's a laborer by occupation. All he and his friends say that, just do whatever best you can, and we are agreeing to whatever treatment. The problem in a corporate setup or in a private setup is that the patient does not have any money, and there is no assurance that any money is going to follow. The other case scenario is a very well-off a patient, he's 55, he's drunk at the wheel, he's asleep at the wheel, and he has a head-on collision with another car. He comes with a head injury, bilateral shaft femur, bilateral tibial plateaus, surgical neck humerus fractures, and he's accompanied by too many relatives and too many friends. The family is very aggressive. They are in denial. They do not consent for any intervention, including a serum alcohol estimation, because it will negate the insurance claim and a patient will have to bear all the expenses. Patient's images of a diffuse axonal injury, the bilateral femoral fractures, tibial plateaus, and this. You do the primary survey and you arrive at a conclusion as what is to be done. Now the problem comes of consenting the patient, that both the cases, something orthopedic or some intervention needs to be done. The essential ingredients for a consent is that we have to have some competent patient. We have to disclose all the information. And we also discussed previously whether you'll disclose all the information or you'll partly disclose the information. So whether you're going to have a true consent or an informed consent. That is a topic for some other webinar itself. It's quite a detailed topic. And the last thing is voluntariness of the patient who's giving the consent. Now, the challenges of obtaining a consent in an orthopedic scenario, in orthopedic patient, is basically our patients generally who present with a trauma, they are meeting you for the first time. They may be conscious, they may be in a state of shock, they may be very irritated because they must have suffered an accident not because of their mistake. The admission is completely unexpected, it is completely unplanned, and so two of the three ingredients, the competence and involuntariness, they are lost. So you're already beginning with a disadvantage. The bigger problem is the patient recall about the consent process. So when you're consenting something during an acute illness, whatever you tell the patient may say that I have no recollection that you ever told me all these complications, or I have no recollection of that, this was all told to me, or an option was given to me. So there is difficulty of retaining the information. There is a difficulty of processing the information, and there is also difficulty of imagining what is going to happen to me in the next few days. So all in all, these are all ingredients for a bad outcome and an unfavorable outcome. And these are incidences when there is a lot of problems happening between the doctor and the patient as a relationship as a whole. So what we designed was something like a multidisciplinary team meeting. In a we have borrowed this idea from an oncology or a tumor board. I mean, any of you who is associated with the oncological setup, they have something called as a tumor board, where a radiation oncologist, medical oncologist, surgical oncologist, and the patient's relative and the patient, they sit in the meeting together to formulate a treatment plan for the patient. So what is this MDM? So this is basically we all sit together, all the health care providers who are involved in treating the patient, they present the critical information in an effective way. So we call all the patients, patient's family, the patient's friends who are sort of, going to help him take a decision, educate them about what is happening with the patient. What do we discuss in this? We discuss end of life issues. We discuss prognosis, the course of treatment so far, as I said, the good news and the bad news. If there is hope for improvement, if all the possible complications which are there, if the patients ask for percentage, kitna guarantee hai, all those dialogues which need to be given to the patient, that there is no guarantee of any particular thing, but the only guarantee is that we will do our 100% for the betterment of your patient. The expenses and the ICU stay if required. So to extrapolate this to a joint replacement or to a complex elective surgery or elective spine surgery like a scoliosis, the same thing is being done, but this is done in a much more slightly relaxed manner, because the rapport has been developed between the patient's family. They have technically agreed to go ahead with the surgery. So in these meetings, apart from the clinicians, the different specialties, like let's say medicine, general surgery, neurosurgery, plastic surgery, whoever is involved in taking care of this particular patient is involved, along with the hospital administration. From one person from the admin and one person from the finance is also involved to explain to the patient what is going to happen. When do we do this meeting? We do this in case of polytrauma. We try to do this as soon as possible whenever the CT scan and the initial information is done, and then we do it on a regular interval. So in our hospital, we have sort of devised that if the patient is staying in the ICU for more than 3 days than planned, we do it every 3 days. If the patient becomes a chronic patient, we do it every 5 days. If the patient is in the ward for, let's say, more than 7 days of expected admission, then we do a meeting once in a week at least with all the patients who's there, all the patients' relatives. Let's say, for example, there's a fractured neck femur which has complicated, he's got urosepsis, is lying in the ICU for a longer time, or who has probably sort of a periprosthetic fracture who's not mobilizing as well. We do this MDM meeting again in the OPD block. We call all of them, all of the interested parties, and do it. So do it basically as often as you think is required to explain to the patient's relatives properly exactly what is happening, especially in VIP patients. You think that this patient is sort of, you don't get good vibes from the relatives. You want to talk to them, and communication is the key here. So you do it as often as is required. In our hospital, we have identified a couple of side rooms where we do. Otherwise, there is a library where there is a separate room which is meant for that, and we call it the MDM room. This is recorded, the consent of the patient's relatives, and it has been told upfront to them that you can record the meeting if you want to, but we are going to record this meeting. So we are going to explain all the possible complications, the expenses involved, everything is told to them. So there is a voice recording in the room. There is a CCTV which also records the video. So make sure you consent the patient's relative that this is going to be recorded. Very rarely have we come across a situation where the patient's relatives say that they don't want a recording. Then we explain to them very nicely that it is better for both the parties that this is recorded. It is not for the purpose of, sort of pointing fingers that, oh, we told you all these things and then you still did not comply. No, it is not for that. It is basically just for the sake of our quality control. Our administration wants to see whether there is a shortfall in our standard of care or the treatment that we are giving the patient. So it is in their benefit and our benefit as well. At the end of the recording, it basically takes about 45 minutes or so very easily in a sort of a polytrauma situation or in a very highly charged atmosphere. But what we have found is that most of these meetings end on a very cordial note. This is the sort of a paper or a communication record. Now, I mean, if people are seeing this on a smaller screen, you might not be able to understand what is written, but I'll just read out to you. This is the second patient, and we have enumerated the diagnosis, the problems that the patient had, the issues that we have discussed, the prognosis of the patient, and the possible complications. There is the name of the patient's attendant, whoever attended, and the names of the patient, of the doctors who were involved, along with the administration staff, the nursing staff, and the billing person who was there during the counseling. So eventually, I will just like to close the cases. We proceeded with the damage control orthopedics. Eventually, we shifted the patient to the ICU. As expected, the patient developed ARDS. He had a lot of issues with his chest, but he sailed through all that. We did the internal fixation later on. Coming to the first case with the guy with the crush injury, unfortunately, he did not land up with a very good outcome. He developed chest-related problems. He fought very hard. And here you can see that again, the number of doctors who are involved is the nephrologist, the chest specialist, the general surgeon, the insurance coordinator, the marketing personnel, the person from the admin ICU. At the same time, this is the room where the MDM meetings are being conducted. But in the photo, you can see Dr. Chandak when he had paid a visit to our hospital. And as I said, we have a very big department. So we keep on discussing these cases. We take independent opinions from our colleagues. We tell the patient, you want a second opinion? We have a second opinion if you want to take it from someone from our team or some of the senior colleagues who are there in the department. If they don't want a second opinion from those, they are free to take the papers elsewhere and take a second opinion and come back to us whenever they have made up their mind. So the important thing is to have friends and colleagues. I am blessed in our department to have colleagues who have unfortunately been around at the time when this incident happened in 2001. So a very rich experience comes from them. They have sort of, seen the things unfold with their own eyes, and therefore they were able to sort of, agree and formulate to these particular problems. And these are all of the colleagues who were there, and this is our department. I would thank you very much, and I'm quite happy to take any questions regarding this matter.